We recently passed the Affordable Care Act, and a big part of that Affordable Care Act, even though the primary purpose was to insure uninsured Americans and make healthcare affordable for everybody, a big part of it was actually looking at Medicare and trying to get the costs under control in the Medicare program, partly to free up resources to help cover the under 65 population, but partly to make Medicare itself more sustainable. And so if you look at the chart on the trajectory of what costs were going to be without the Affordable Care Act, the blue line, you can see it growing up in billions up to close to $1 trillion by 2018 or 19. And the Affordable Care Act brings that, as the red line, brings those costs down a little bit below what was projected. And so part of what the Affordable Care Act is trying to do is reduce the rate of growth to about 6% on average per year for Medicare, down from 8% a year, which is what it's been for the last 20 years. We're all excited that we're seeing a dip in the rate of growth in costs in 2012, 2011, 2012. That could be for many reasons. Some of it is no doubt due to the economy, the fact that people don't seek elective surgeries or don't seek a lot of extra care when they don't feel that, when they think they're financially insecure, don't have a job. Some of it, however, might well be due to the Affordable Care Act, particularly some of the more immediate provisions around cutting rates of payment, and possibly even related to some of the transformation of the system that the whole sector is experiencing today. But what you see is this in this chart is that there are dips in the rate of growth and costs that have been going on for decades. They generally dip for a while and then pop back up again. And what we don't know about the Affordable Care Act is whether or not there will be another pop-up. But we are now, fortunately, in a dip. And that is actually one of the reasons the sustainable growth rate is the projected cost to fix it is so low right now, because costs have come down below what they were projected to be, but even as recently as 2010, which makes it a great time to try to fix the sustainable growth rate formula. But the biggest sources of cost savings in the Affordable Care Act, at least as projected in 2010 when the Congressional Budget Office made the calculations, was that paying Part A providers less, which was a negotiation with the providers, would save $196 billion. And then reducing the amount that Medicare and Medicaid pay to hospitals to take care of the uninsured would save $22 billion. Reducing payments to the Medicare Advantage plans to bring their rates, their premiums, closer to what it would have cost if people had been in the traditional Medicare would save $135 billion. And then other pieces, increasing high income, the high income adjustment to Part B premiums is supposed to bring in $25 billion additional dollars, and creating an independent payment advisory board to bring in another $16 billion. What's interesting in all of the Affordable Care Act and all of the desire to restructure the provider payment and delivery system is the Congressional Budget Office didn't give it much credence in terms of how much money it might save. And that's partly because they didn't have much to go on. And so we're going to have to find out how much the delivery system changes affect Medicare costs. But I'm going to go over some of these specific policies that Congress put in the Affordable Care Act so we have some idea what they mean. The first one was the reductions in payment to the Part A providers. What you see here is a chart that shows you the rates of Medicare profit by provider type, Part A provider type. Now, the acute hospitals is the lowest line, it's the red line, and what it looks like here is that Medicare pays below cost for the acute hospitals, and has for many years. However, one of the considerations that acute care hospitals have is that they can spend more than Medicare pays them because they can charge the private sector a lot more. And when some hospitals can't do that because they mostly serve Medicare or poor people, and when you see a hospital that can't what they call cost shift or charge private sector for what Medicare doesn't pay, they tend to live within the Medicare payment rate and make profits. So there's some concern with that red line that looks like Medicare pays below cost, that the cost is inefficient cost, and it wouldn't be as bad a payment ratio if the hospitals were more efficient. But looking at the other institutional providers or post-acute providers in Medicare, you see that their profit margins from Medicare range from around 5 to 10% for the hospice programs to as high as 20 to 25% for some of the other providers, skilled nursing and home health. And those providers are taking rate reductions. But as you can see, their profit margins from Medicare are quite significant. Their argument that they don't want rate reductions is more that they are actually subsidizing Medicaid. They take care of a lot of poor people and older poor people. But the Medicare program, many of us would say, overpays these post-acute providers, and the rate reductions are probably something they can absorb and are sustainable. Another option is to keep increasing high-income adjustments, the premiums to people who have high incomes. So what the Affordable Care Act did was raise the premiums for people who have what they call high incomes, and I'll leave it to you to decide whether your income's high or not. The definition of high income is currently frozen at $85,000 for an individual and $170,000 for a couple. So if you make more than that as an individual or as a couple, you're going to be paying more than the standard rate for your Part B premium. If you make a lot more than that, maybe you don't care, but you'll be paying roughly 85% of the actuarial value of your Part B benefit. So Congress has greatly increased the amount that high-income people pay towards Part B. And that's because they can't increase the rates for the lower-income people because they don't have the money to pay for it out of their Social Security check. Another feature of the Affordable Care Act was to create the Independent Payment Advisory Board. This may or may not ever happen, but it's an effort by Congress to create a board that tells Congress what it has to do because Congress can't make itself do it. So they were going to, the idea is that 15 members would be appointed by the president. One of the downsides to that is they have to be confirmed by the Senate, which means that they have to get through a confirmation process, which Congress hasn't been so great at in recent years. But that, let's just say they do achieve, get the members appointed. Then they have to recommend proposals to reduce costs if the rate of growth in Medicare exceeds certain targets. Because of the reduction in the cost growth that we've observed in the last couple of years, it doesn't look like we would need this board to make any recommendations until 2020 at the earliest. And then they can only really recommend payment reductions to providers because they're limited in terms of where they can seek to have Medicare costs reduced. So if they have to make these recommendations, they have to be implemented unless Congress comes up with legislation to have the same financial impact, but on hitting different targets. The part that makes this not the most powerful board is that Congress can also fast-track consideration of just getting rid of it. So it's Congress saying, I need some discipline, but I don't really want the discipline. So finally, the last place, and probably the place I have the greatest hope for making Medicare sustainable is in reforming the delivery system. Right now, Medicare pays fee-for-service, traditional Medicare pays fee-for-service to siloed providers. In other words, providers who are operating independently. The primary care doctor who's independent from the specialty doctor, who's independent from the acute hospital, which is independent from the post-acute hospital, which is independent from the pharmaceutical side of the business. So everybody's getting paid to do more, and nobody's talking to anybody or coordinating the care. And here the patient who has a medical condition is just a collection of parts getting treatments from different types of services without anybody talking to anybody. This is inherently inflationary and it's terrible quality. And so the Affordable Care Act really tries to change that. Now, this chart is hard to follow, but the concept here is you can't change the payment system until you can change the delivery system. So if you want to start paying people for a bundle of services or for fixing a medical condition, whatever it takes, or even a year of care, you have to put the providers together to talk to each other and create an organization that can accept that kind of payment and actually improve the care and integrate the care and create the information systems and the teams and the protocols to improve the care across those different silos and services. So that's the big challenge. That's what the private sector and the public sector, Medicare and the private insurers, and the delivery system are trying to do today when they talk about affordable, accountable care organizations, patient-centered medical homes. They're trying to get the delivery system integrated under some kind of common platform, whether it's through ownership or agreement or shared services, and get them to take care of the whole patient and accept a payment for the whole patient. And hopefully that will change the way the delivery system works and make it more efficient and much higher quality. Another big part of this is to take, the Affordable Care Act tries to push people the providers to take responsibility for the health of the population, so that instead of being penalized when people are healthy because nobody comes into the hospital, they get rewarded when people are healthy. Right now, if a primary care doctor gets really good at taking care of patients with congestive heart failure, the hospital loses money because those patients are no longer coming to the emergency room. So you get this is a huge challenge. It's going to take us a good decade or longer, but hopefully we'll be able to make Medicare sustainable as these providers and payers get together and make this happen. So my last question to you is, what's going to work? What do you think is going to work? And why do you think it's going to work? And will it make Medicare sustainable for our future? Thank you.